Essentials of therapeutic communication. Communication. Communication is not just talking, it's a back and forth process where we send, receive, and interpret messages. What I say and what you hear may not always match. Each conversation is shaped by context, culture, and emotion, making every interaction very unique. When communication is unclear, mistakes can happen. For example, a poor handoff could mean the wrong medication or delayed care. Beyond patient safety, poor communication also affects us as nursing professionals. It can damage trust with colleagues and patients. Essentials of communication. So we communicate to share both information and emotions. For example, when we explain a treatment plan, we're giving information, but we reassure a patient. We're addressing feelings. We also influence patient responses, encouraging healthy behaviors, and gather critical information from them. So the types we have verbal. This includes speaking and listening. Tone and clarity are just as important as words are. Nonverbal, now these are gestures, posture, facial expression, often reveal more than words do. For instance, a patient may say they feel fine, but then have their crossed arms in a tense position, an expression that may suggest they're really not fine. Written communication is documentation, notes, or even emails to ensure continuity of care and accountability. Electronic technology like patient portals, text messages, telehealth platform is becoming very important for quick and accurate information. So the impact really means effective communication equals better outcomes. Effective communication builds trust, prevents misunderstanding, and improves patient outcomes. Poor communications, on the other hand, can cause errors, damage trust, and even compromise safety. So, therapeutic communication is a foundation of nurse-client bond. It's essential for safety and care. Therapeutic communication is really the heart of nursing. It builds trust, supports healing, and helps us gather accurate information. More than that, it keeps our patients safe. Without effective communication, even strong clinical skills won't ensure safe, competent, and compassionate care. So it's a process. A stimulus is the need for information, right? Everything starts with the need. For example, a patient feels and needs to let the nurse know that I am having pain. So that is the stimulus. Another example is a nurse needs lab results from the doctor. That's a stimulus. Everyday routine, when you're talking to someone, there's a stimulus that kind of starts your conversation. So sender is the person who begins a message. The sender is a person who speaks first. So using our patient example, the patient says, I have pain. But remember, the way they say it depends on their background, culture, past experiences, mood, and even knowledge. So for example, one patient may say calmly, I'm in pain. Another patient from another culture may be moaning, crying, or even from the same culture, maybe crying, moaning, and without using words at all. So while one is saying verbally, I'm in pain, another is expressing pain through nonverbal messages. So message, what is communicated. The message is the actual content being shared. It could be, like I mentioned, verbal words, I'm in pain, nonverbal, body language, holding their strong stomach, grimacing, or refusing to move. So sometimes both, and they may match. Patients may say they're in pain and also look like they're in pain. Or a patient may contradict. A patient may say, hey, I'm fine, but tears are rolling down. Or a patient may say they're in pain, but they're, watching TV, feeling happy. So if example in nursing really is like if a patient's saying I'm okay, but is guarding their surgical site, you should trust both the verbal and the nonverbal and really kind of assess the patient and see what exactly is going on. A transmission of quality is how clear the message is. Even a good message can get lost if it's not clear. So, if a patient's mumbling, rambling, speaking another language, or if the nurse is distracted, the message may not come across correctly. Another example is giving too much medical jargon, like saying your sodium levels are low, and patient would be like, this sounds like Chinese. They don't know what that is. Clear, relevant language is key. So, receiver who hears the message, this is a person who's hearing the message. A receiver is the one who listens and interprets. So, in our example, the nurse hears, I'm in pain. But just like the sender, the receiver also has personal filters. The nurse is probably stressed out, has worked the whole day. So the nurse may think, is the patient exaggerating? Is it really the patient in pain? Another nurse might immediately think, I need to assess this pain. So it's your own attitude and your own what you're feeling. This is why, your attitude and your bias, you have to be very mindful of that. So, feedback is a response that the person gives back. The receiver then responds, and that's their feedback. So, they could give verbal, like, okay, I'll bring you your pain medication. Or nonverbal will be nodding and smiling while adjusting the IV, or both together, saying, okay, yep, they're nodding the head that I will get that for you. Example is if the patient says, yes, that helps after your position, that's also feedback. And they can also have just like negative or another negative feedback as well. So verbal and nonverbal feedbacks are given by the receiver. Verbal communication essentials. Use of spoken or written words, central to effective interaction in all settings. So verbal communication means using words, right? Either spoken or written. It's how we connect with patients, families, and other healthcare workers. Asking a patient, where's your pain, or documenting patient reports a headache of 7 out of 10. So there's some key aspects of effective verbal communication, and that is what we do. Key aspects of verbal and effective communication is our pace and annotation. So it's how fast you talk and the tone of your voice. If you rush through discharge instructions, the patient may not catch important details. So being calm with a steady tone reassures a nervous patient. Be simple. Use simple everyday words, simplicity. Example, like instead of saying you have hypertension, you can say your blood pressure is high. Clarity and brevity, so be clear and don't overload with too many words. Instead of saying, at this time, you're going to require medication administration, just say, you need medication now. Time and relevance, picking the right time and keeping it meaningful. Don't try to teach a patient about diet changes right after they wake up from surgery, for example. Adaptability, adjust to the situation and the patient. Like with a child, you might use simple phrases like this will help, or this will pinch a little. With an adult, you might give a little bit more detail. Be credible. Patients need to trust what you say. So if you don't know an answer, be honest, I'm not sure, I'll find out for you. That builds trust. And sometimes we can use humor when appropriate, as it can reduce stress. So light humor when a person or a patient is nervous, like joking, can help. For example, saying like, hey, the gown is straight from Paris week, or can make them smile. But always avoid humor that can seem insensitive. So don't overdo the humor, but sometimes it can work and it can help reduce stress. So nonverbal communication are gestures. These are, for example, a patient waving their hand to say no if they don't want to speak. A nurse using hand signals like pointing to the call bell. Facial expressions. The face often speaks louder than words sometimes. A nurse grimacing or a patient grimacing when in pain, even when they're saying I'm fine. A nurse smiling while greeting a patient shows warmth and care. Body position and movement. How someone stands sets your moves. So standing with arms crossed might seem defensive. Sitting at eye level with the patient instead or of hovering over them builds trust. And sometimes we could use touch. Touch can comfort or reassure, but must be appropriate. Example, like holding a patient's hand before surgery can help calm them, but always respect boundaries. Some cultures may not want touch, so just be mindful of what culture it is. Personal appearance, your clothing, grooming, hygiene. A clean, uniform, and neat appearance communicates professionalism. A disheveled look may reduce patient confidence in your care. And always respect the personal space, how close we stand to others. Patient may feel uncomfortable if you stand too close while talking. But during care, like inserting an IV, taking vital signs, you have to be in their personal space. So always explain first. And impact of nonverbal cues. Nonverbal messages can reinforce or contradict what is said. So saying I'm happy you're here, but rolling your eyes sends a mixed message. Looking at your cell phone while the patient is talking to you. They can reflect cultural, social, and personal norms. In some cultures, eye contact also shows respect, while in others, it is considered rude. In an American culture, you look at patients in the eye, and that shows respect. In Asian cultures, it's not seen as being normal. It's seen as being as disrespectful. So this slide shows how our body languages can send very different messages, even when we don't say a word. So as nurses, we need to be aware of both our body language and how patients' body language. So let's go through some of this. So openness versus defensiveness. When someone sits relaxed with open arms, they appear comfortable, approachable, and open to conversation. But crossed arms and stiff posture can look defensive, like they're closed off. And then if you see here, expectancy versus frustration. Leaning forward or sitting upright can show interest in being attentive. On the other hand, tapping, fidgeting, slouching may be seen as frustration. A patient waiting for a lab result may lean forward eagerly, but if it's delayed, they may start showing off frustration signs. Evaluation versus suspicion. Stroking the chin or tilting the head often shows someone is thinking or evaluating, but if they look tense or suspicious, they may doubt what's being said to them. Self-control versus nervousness. Sitting calmly with hands together shows self-control, but constant fidgeting, nail biting, or tapping fingers may reveal nervousness. Readiness versus boredom. Leaning slightly forward and alert shows readiness to act. Slouching or looking away often signals boredom. Confidence versus insecurity. Good posture, eye contact, relaxed shoulders reflect confidence. Avoiding eye contact, looking down, closed body posture often shows insecurity. So really, the takeaway is our body language communicates just as much as our words. Always observe your patient's nonverbal cues and be mindful of what you're projecting with your posture and movements as well. Personal space or proxemics refers to invisible boundaries we maintain when interacting with others. In nursing, respecting these zones is key to building trust and comfort. So, intimate space is like close touching 1.5 feet. So that's for very close relationships. In healthcare, we often enter the space when we're performing physical exams, giving injections, performing vital signs, or providing personal care. So, assisting a patient with bathing, etc. Always explain what you're about to do before entering the zone so patients don't feel violated. Personal space. Now that is 1.5 to 4 feet. Common for conversations with friends or family. Nurses often use this space during patient interview at the bedside, so sitting very close to the patient to discuss their plan of care. Social space, used in more formal interactions. In nursing, this might happen between teaching sessions or when addressing a group of family members in a waiting room, explaining discharge instructions, etc. Public space, that's 12 feet plus, typically for lectures, public speaking, or large group interactions, a nurse educator giving a presentation, etc. So basically, knowing these zones helps us approach patients respectfully. Some cultures may prefer distance, while others are more comfortable. So you want to be mindful of who you're speaking to and what their cultural background is. Electronic communications, advantages, disadvantages, and when not to use them. So some advantages are patient portal allows patients to securely view their lab results, appointments, and send non-urgent questions too. Sometimes if you can message a patient via a online portal, text messages work well for some patients as well, like for vaccination reminders for clinic appointments, etc. Email provides quick written communication and supports continuity of care. There's some disadvantages. There's always a risk in that confidentiality if information is sent to the wrong person or device. Not all patients have equal access. Some are not tech savvy. Some may lack interest, smartphones, or digital literacy. So it could be misused, for example, staff checking personal messages during work hours. And some of our elderly patients don't have the current devices. They may have a flip phone. But not to use electronic communication, never for emergencies or urgent issues like chest pain or shortness of breath. Patients should call 911. And don't share abnormal or highly sensitive information like, for example, a cancer diagnosis through a text or email. These require more of a face-to-face conversation with the provider. So the important things about electronic communication is that it's a useful tool, but it must be used safely, ethically, and appropriately in nursing practice. Essentials of effective written communication. So purpose, document, and instruct. So really, writing is how nurses prove they gave the care that they gave. If it wasn't documented, it wasn't done. So charting vital signs, writing discharge instructions, writing admission notes, progress notes, etc. You will learn more about that in a few weeks, but there are some challenges since writing has no body language or tone. You have to keep it short and precise and to the point. So instead of saying, instead of the patient said they were kind of having pain but didn't explain much, you will instead write patient reports pain, no number given, or whatever number they gave, right? Nursing notes, example, denies chest pain, lungs are clear, oxygen saturation is 98%. So something you want to document in a objective way. Discharge instructions, for example, wound care provided, follow-up, visit date, etc. Patient education sheets, memos, emails to staff or administration. So you want to be clear, clarity and brevity, short and to the point, right? Accurate language, use proper terms like blood pressure 140/90, not blood pressure is high, right? Right? Document effectively. Grammar, punctuation, avoid mistakes that change meaning. Logical order. So if it's a head to toe approach, soap note before note, approach, star note, etc. And cite your sources. This is an example of an effectively written email. Always, if you see here, begin with hello, doctor, hello, professor, hello. Don't start with hey, hi. That's too casual for school or professional communication. If the professor later tells you you can call them by their first name, then you can certainly call them by their first name. But until then, stick with formal. So this email is clear. The students right away, they're very professional and they are using clear communication. Polite, and it's a polite email. It's organized. There's a greeting, introduction, purpose, request, closing, easy to read and follow. So as future nurses, professional communication matters not only to instructors, like you're sending emails to us, but your supervisors, and you have to be professional in your charting, and you would learn about professionalism as well. But it's writing clearly, politely, and to the point avoids misunderstanding. And this is an example of an unprofessional email, which is not good communication. As you can see, too vague and dramatic, all caps, sounding like they're shouting, and very informal. Hey, demanding and unprofessional. Clear doesn't explain the specific situation, and then request sometime soon is very vague, missing information. And this is a citation example, APA. The essence of communication in healthcare. Foundation of care connects patients, nurses, and healthcare team. And so communication is the heart of all patient care. When giving report to another nurse, if you leave out important facts, for example, the patient is allergic to penicillin, and you forgot to mention that to the oncoming nurse who's taking a report from you, and they don't know. They busy taking care of patients, and they have to get a report from everybody, so that can kind of come back and be unsafe for the patient. So, patient centered, speak simply, avoid jargon, always consider what the patient can understand. Instead of saying you have hypertension, you have high blood pressure. Listening matters. Listening is more than just hearing words, it's also noticing tone, body language, and expression. A patient may say, I'm fine, but keep, tapping their hands, becoming fidgety. That's a non-verbal cue that you should follow up on. And every patient is different. Adjust how you communicate. An older adult who's pretty hard of hearing may need you to speak slowly and face them. With a child, you may use even more simpler words like tummy instead of abdomen. So nurses are the bridge. We gather information, we clarify needs, and make sure patient understands. We are upholding safety standards. Instead of writing, patient verbalize abdominal discomfort, right? Patient reports stomach pain. And be short, clear, and professional. Key concepts in communication for healthcare. So interaction, communication links the care team and patient. So miscommunication between nurse and physician can delay treatment. Comfort, pain assessment depends on good communication. A patient saying it hurts a little may actually mean severe pain. So ask clarifying questions. Grief and loss requires empathy and awareness of cultural differences. Some cultures may openly express grief, while others may stay silent. So respect both. Intracranial regulations. So neurological problems like stroke or traumatic brain injury can affect speech and understanding. So a patient with aphasia may nod yes to everything, but they don't really understand. So don't assume agreement that they understood. Have them repeat back. Confirm carefully. Mood and affect. Mental health conditions change how patients communicate. A depressed patient may give short, flat responses. Be patient and be supportive. Oxygenation. Low oxygen makes it hard to speak full sentences. So for some people may have conditions like COPD, chronic obstructive pulmonary disease, may only get a few words out. So with those patients, you may have to use other therapeutic communication styles to reduce strain. Safety errors often come from unclear instructions. Example, so like take one pill daily is more clear than take as directed. So give good instructions. Now, these are therapeutic techniques, and this is something very important. We will talk about these in detail in class. We will go through all of these in one by one, but just these are the therapeutic techniques. Active listening, pay close attention to words and nonverbal cues. If the patient says, I'm scared about surgery, the nurse will lean forward, nod, and say, tell me more about what makes you scared. Broad opening, let the patient choose a topic. What would you like to talk about? Clarifying, clear up confusion. When you said you feel weird, can you explain what you mean? Exploring goes a little deeper into feelings and ideas. Can you describe the pain feels like? Focusing, keep the conversation on track. Let's go back to your concerns about taking the new medication, for example. Redirect it back. Informing provides accurate information. The medication may make you drowsy, so avoid driving at first. Offering self shows presence and support. I'll sit with you until your family arrives, for example. Open ended questions. Invite more than just yes or no. How are you coping with your diagnosis, for example? Paraphrasing, restating in your own words. So the patient says, I feel very tired. The nurse can say, you're saying you feel exhausted often? Reflecting, turn the patient's thought back to them. Do you think I should go to rehab? The nurse will probably say, well, what do you think? What do you think would help you most right now? Restating, respect the patient's own words. Patient says, I don't want to eat. You maybe restating, you don't feel like eating. And sometimes we have to use silence, allow for pause for thinking. So patient hears bad news, the nurse kind of sits there quietly, not rushing through or asking questions. The patient just got told they have cancer. It's best to give silence so the patient can absorb that. Summarizing, wrap up main points. So today we talked about your pain, your new medication, and your discharge plan. Validating is confirm mutual understanding. So you're saying that the dizzying started after you took the pill, correct? So that's validating. So these are some examples of non-therapeutic techniques. So approval, patient says, I'm going to start a new diet. The nurse says, oh, that's exactly what you should be doing. So this will make the patient feel judged by the nurse. Asking excessive questions. Do you smoke? Do you drink? Do you exercise? Take vitamins? Are you stressed? Do you eat fast food all at once? Could feel like interrogation. So slow down. Ask one question at a time. Changing the subject. I'm scared about the surgery. The nurse instead says, hey, let's just talk about your discharge paper. Not even kind of talking about surgery. Avoids the patient's real concerns. Closed-ended questions. Did you sleep well? Yes or no? That shuts down the conversation. It's better to kind of redirect that question and say, tell me about your sleep. Tell me about your sleep last night. Disagreeing. Patient says herbal teas, for example, don't help me. Oh yeah, nurse might say, oh, yes, they don't work. And validates the patient's belief. Or the patient will say, those help me, and the nurse says, no, they don't work. Disapproving, patient says, I drink sometimes while on meds. And then the nurse says, oh, that's really bad of you. So that sounds judgmental instead of supportive. False reassurance, the patient says, I'm worried about the test result. The nurse says, don't worry, you'll be fine. So that dismisses fear instead of exploring. Giving advice, a patient says, I'm feeling nervous about my symptoms. The nurse may say, you should just relax. Tell the patient what to do instead, empowering them. That's what you should do. And then it really, giving advice tells the patient what to do instead of really empowering them. That's not good. The patient would be like, what is, this nurse doing? I'm expressing myself. I feel nervous about my symptoms. And she's telling me to just relax. Minimizing the client's feelings. So the patient says, I'm upset about the delay in my diagnosis. The nurse may say, at least it's not cancer. So it downplays the patient's real feelings. Parroting. So the patient may say, I'm worried about the side effects. And then the nurse will parrot that back. You're worried about the side effects. So it feels robotic, shows no real understanding and connection. Placing the client's feelings on hold. So patient starts crying. The nurse instead says, we'll take your meds first. Pushes aside the patient's emotions, for example. Valley judgment. Patient says, I don't vaccinate my kids. Nurse will say, I don't see how a good parent could refuse vaccinations. So imposes the nurse's It really imposes the nurse's morals, and it feels like attacking the patient. And finally, why questions. So, why questions are the worst. Patient, I miss my meds. Why didn't you take your medicine? Why do you always miss your meds? Sounds critical, makes patients defensive. Factors influencing communication in healthcare. Developmental stages. So, age and maturity affects how people understand and share information. So, if a nurse is explaining procedure with simple words and pictures for a child but uses medical terms with an adult. Gender differences. Men and women may have different styles of expressing emotion or asking questions. A male patient may give short, factual answers, while a female patient may describe more details about feelings. Values and perception. A person's background, belief, and past experiences shapes how they interpret messages. A patient who values natural remedies may view prescribed medication as with skepticism. Personal space. Comfort levels vary in how close others can get. Some patients may feel uneasy if the nurse stands too close, while others may actually appreciate the touch or and find it comforting. Barriers to communication. So things that block clear communication, such as language differences, hearing loss, or medical jargon. A patient who doesn't speak English may not understand discharge instructions. So always use an interpreter. Roles and relationships, how patients relate to each other, professional, patient, family, changes how they communicate. So a nurse may use formal, respectful language as a physician, but may speak a little bit more casually with the patient's family. Environmental factors. Now, that could be the setting that can affect communication. A noisy, area would be difficult to kind of convey messages in. And so noise, privacy, comfort all matter. A patient may struggle to focus on instructions if the TV is on in the background that is very loud. And congruence in communication. So what that really means, congruence, is that your verbal and nonverbal messages should match. So if a patient says, I care about your pain, but avoids eye contact and looks rushed, or maybe checking on their phone, the patient may not feel believed, right? The patient may think, oh, I don't think she understands. So you should, if you care about the patient and you're talking to them, you should look them direct in the eye. So your verbal and your nonverbal message should be identical. Your tone should be calm. You should be in eye contact and then speak with the patient. So if it doesn't match, that's that's what congruence and communication, verbal and non-verbal messages should match. Interpersonal attitudes. Attitudes like respect, warmth, or judgment influence trust and openness. A patient may open up more to a nurse who smiles and listens rather than the one who seems impatient or rushed, or becomes task-oriented. Effective communication and client-centered care. Understanding needs. Always watch both words and body language of the patient. If the patient feels or says, I'm fine, but looks sad, tearful, don't ignore it. Ask them, I notice that you look upset and you're crying. Would you like to talk about something? Adapt to impairments. When a patient is hearing impaired, face them when speaking. And with cognitive issues like dementia, use short, clear phrases. And some other things to consider: children, use simple words, get at their eye level, and use play. Instead of saying, let's talk about your temperature, say, let's see how warm your body is with this little beeper, for example. Older adults, speak clearly, make sure they have their hearing aids and glasses on, reduce background noise, sit close, speak slowly, and allow extra time for answers. And cultural sensitivity, always use interpreters when language is a barrier. Never rely on children or other family to interpret. Provide discharge instructions in the patient's preferred language. Always talk to the patient, not just the interpreter. And the environment should be quiet. Private setting shows respect and improves focus. So if the TV is loud, kindly ask to lower the volume before starting. Set goals. Like for example, say, let's go over your medication today so you feel confident taking it at home. Implement, build trust with consistency and honesty. If you don't know the answer, say, I'll find out and get back to you. Show empathy. If the patient says, I'm scared about surgery, respond that it's normal to feel that way. Can you share what worries you the most? Match your words with your body language. Don't smile if the patient is crying. Maintain open posture, face the patient, avoid crossing arms, not to show that you're listening. Understanding groups in healthcare. So, groups in healthcare, by definition, are three or more people working towards a shared group. The main reason groups exist is to get things done that one person alone cannot achieve. So there's a couple of types of groups. Formal groups, they're organized with clear roles like committees or task forces that solve certain problems. Then there's informal groups. Those are more casual, like support groups that you can make with other nurses or during a break session. So, group dynamics, the way groups work depends on leadership, how members interact, and how they communicate. For example, a strong leader and clear communication can make a group successful. So, think about a nursing manager. Nursing manager that has good leadership skills can manage the group in the, say, med-surg floor that he or she is managing, and a good manager can have a very positive dynamic in group. Levels of formality. Some groups are very structured, like official hospital safety committees. Others are casual, like a quick team huddle at the nurse's station. Characteristics of effective groups. Good groups have teamwork. They work together, they're organized, and they communicate well. So as nurses are often part of both formal and informal groups. You'll notice that when you're working on the floors and you're in clinical, you're going to notice formal and informal groups. They help make decisions. Nurses are part of the healthcare team. They have shared information, improve patient care through these groups. References.